Hello and welcome to this edition of COVID Ethics Update, a service of the Center for Practical Bioethics during the COVID-19 pandemic. Thank you for joining us. My name is Terry Rosell. I serve as the Rosemary Flanagan Chair at the Center for Practical Bioethics. Our topic today is the effect of coronavirus on spiritual care. And I have with me today my colleagues, Kathy Riegelman and Sally Schwab, Reverend Kathy Riegelman, Reverend Sally Schwab, both are spiritual care providers in hospital facilities in the greater Kansas City area. And I have some questions for both of you because I have been curious about how spiritual care is going during very, very challenging times and the restrictions that we're all placed under during the pandemic crisis. So how is this pandemic crisis, with lots of restrictions on all of us, how is this affecting spiritual care in your facilities? Kathy or Sally?
Well, it certainly is affecting us, and thanks, Terry, for putting this together. I think it's an important topic, and I think the main thing is to know that we are being really innovative, both as an organization and as a department, to try to find ways to keep those connections with our patients and their loved ones and with our staff here in the hospital. It's been very different to have restrictions on visitors. So we are coming up with ways to reach out to them with either telephone or via different kinds of technology so that we can try to have them as present with us as possible. I think that while these ways of reaching out, obviously have some limitations, they have really helped us to be able to keep connections, especially with those families that can't be here right now. The need for spiritual care at this time seems to be very important. And one thing that I will say, just as a little bit of balance in my own practice, is that I'm spending even more time supporting the staff in our hospitals as they're caring, for our whole population of patients. That's been a big focus that we've been leaning on. So,
in regard to my response at Mosaic, I was involved in developing a plan for how we would respond as we began to receive positive test results and as we began to have patients within our medical center who were positive for COVID-19. That engagement meant coming up with what level of care a chaplain would be able to provide at Tier 1, at Tier 2, Tier 3. Ours goes through Tier 6. We currently sit at Tier 4. And so that has, as I developed that tier plan, I did that with my team of chaplains. And so we developed the plan. It wasn't me developing the plan, and then I presented it to our command center, and they accepted that plan. And so what we have done is that because we're at Tier 4, we are not doing a lot of face-to-face visits with patients, although we are still doing some. When we are in the clinical areas, we're wearing a mask, which is a bit inhibiting, but not terribly so. And we're doing a lot of our visits over the phone. We call the patient's phone in their room, and we can use other devices on the iPhone. We carry an iPhone, so we can text and do things like that as well. We've also emphasized a lot of getting the spiritual words out into the types of communication tools that we are using. And so, for example, I have been on the overhead once offering a prayer. Then I have been on our connected page, which is our internal communication tool, offering a reflective thought spiritually. This week, my colleague Dan is going to be doing something similar. And then for Sunday, we're going to have a spring blessing on the dietary cards, which is going to be in every patient card, making sure we are respectful of the different diversities of religious experience that people have. So we're looking at all the ways we can be engaged. What I really appreciate is that we were dubbed essential staff. So that we are going to still be here 24/7 round the clock, doing all we can to support our patients and families, and also, as Kathy said, to support the staff, because as our increased numbers of COVID-19 occur, the chaplains will be less face-to-face and will be more engaged with supporting the staff. And I've been involved in several things already related to that.
So you said that you are considered essential staff as spiritual care providers. I intentionally asked both of you to be on this call as chaplains who are working in secular facilities and systems. And then I want to do another call with a couple of chaplains who are faith-based hospital systems. So it's interesting to me that that in your facilities, chaplains are considered essential staff. Is that true also at the University of Kansas Health System, Kathy?
Yes, it is. We have been considered essential, just as Sally said, and my own personal feeling is that we're even more essential right now. So we're being updated constantly on how to keep safe, and as Sally also said, wearing masks when we're out and about. I think there is just a heightened awareness of the importance of spiritual care, both for our patients, their loved ones, and our staff during this time when things are a bit unsettled. So that's, we're an integrated part of the team. We're here.
Yeah, and I would just add with that I think less than it being, are we a religiously backed facility or a secular, what's more important is how integrated is the spiritual care team within the life of an organization. And for example, I mean, I was part of the development of our visitor policy. I've been part of our writing of letters to area clergy and helping them understand what they can do in terms of entering and leaving our facility. Also our funeral homes and the picking up of the deceased. I was part of helping create that letter. Right now, our ethics committee is involved in looking at a potential policy related to what if we have more deaths than we can manage and things like that, and the ventilator issues that are, of course, cycling everywhere. We are hoping that we are well stocked and able, and those questions will never present themselves to us. But those conversations, you know, are bubbling, and there's an essential need for folks in the spiritual discipline to be a voice at the table.
I was going to ask a bit later what sort of innovations you are coming up with during this time so as to provide spiritual care that is both relatively safe as well as effective. But you've already mentioned some, Sally, that are happening up at Mosaic and St. Joseph. Are there any that you think of, Kathy, that some innovations that have been required actually so as to do spiritual care in better ways at KU Med?
Well, I want to turn for just a minute to how we're supporting our staff, because that's where a lot of the innovation has happened. We've been really fortunate that we've been collaborating with our psychology department here and come up with a number of structures to support staff, including group supports on the phone where people can call in and talk to either a chaplain or a psychologist, or there might be a time when both of us are actually on the line to receive those calls and support staff. We're doing one-on-one with our physicians, have a sign-up time where they can call in and have a little bit of time in a more private way to talk about any of their concerns or any of their challenges that they're facing. And again, we're doing just more of that, being able to go out on the units. We're still allowed to do that. So we're going out and just doing a lot of face-to-face. But those collaborations that are happening and with our psychology department has been a great innovation to try to reach the staff that need some extra support at this time, as well as having a lot of resources available on our hospital intranet that people can access electronically, emphasizing the importance of reaching out to the EAP or any other organizations that provide support for people during this time.
I would add that we did, just this past week, we did a leadership Zoom where several of us, including our employee assistance program, talked about resources for our caregivers related to support for our leaders as well as for our frontline caregivers. We also have created cool zones. We have our hot zone, which has to do with COVID-19, and the cool zones are areas in each department that have been created by the department leaders where there's some things to eat and drink and maybe some, you know, colored pencils and things to play with and stuff like that, just to de-stress. And so spiritual health, we have our cool zone. And we also made the chapel into a cool zone. And I think there are probably some people who look at me a little funny about that, but we put a big sign on there that said cool zone, all are welcome. And inside we have meditations that people can use for themselves, or a couple of readings that they can. And then the area, instead of playing really, really kind of easy listening music, we're playing a little soft jazz. And so I know that the chapel is being utilized more now as a quiet space where staff can come in and just kind of be either by themselves there or with a couple of other people in a very special way. So I think that's pretty innovative, that cool zone idea.
Good ideas, and I am so impressed with what's happening in both systems. You both have chaplaincy students that typically are in your hospitals as well. What's happening with clinical pastoral education these days?
Well, in my area, I was between programs. And so I was to have started a program March 23rd. And my students are extended students because we have staff chaplains who are doing the work that sometimes CPE residents do. But the students augment that. And so because they were in a volunteer status, I was basically told not to begin those student programs. And so it is currently on hold, and the students, I have 6 students waiting. The intent is try to begin them sometime in June, but I'm beginning to think we're probably going to wait till July or August, only because we do not want to risk anybody's safety in all of this, and we just don't know yet in our area of the country what this is going to mean. So we do not have students, and so my staff chaplains are handling all of it, and the students are on the sidelines praying for us at this moment.
Kathy, do you know what's happening at the University of Kansas?
Right. Yeah, we do also have a CPE program, and our resident students are still involved and are doing some of the night coverage. We've had to do some adjustment to our coverage so that we are having a period of time from midnight to 6 a.m. when there's part of our intern program, as Sally referred to. These are volunteers that are taking the calls from home. And if there's an urgent need for someone, if they can't handle the call over the phone, they have someone that they can call that can come into the hospital. Otherwise, we do have, between our staff chaplains and our residents, coverage in-house all other hours. I know that our resident program is doing their seminar time on Zoom instead of coming into the hospital and sitting together. So we're very fortunate that, you know, that technology can support their program. I believe our interns are also doing their seminar time that way. So there's been adjustments, and it's been a learning time for everyone. And I think as a learner, this will be something that they will certainly remember from their CPE experience. And in these times that are a little different than we could have anticipated, we are very fortunate to have the support of our CPE program in addition to our staff chaplains. So we're all adjusting hours, we're making it work.
One of the thoughts I had, Terry, was that if I have to extend it longer in terms of the time period, I'm going to invite them to see pandemic as an area of learning, and that I'm going to refer them to the Practical Bioethics website to receive information and then begin to reflect about what all of that means for their own learning in CPE. So
well,
thank you for the resources you provide.
we do have resources at practicalbioethics.org, and we invite anybody to log on and to access them. We're running close to time here. We try to keep these under 15 minutes. I think we're going to go a little bit over because this is very rich. I do have one other question that I have to ask both of you, because this is one of the major concerns throughout the world, really. And that is the concern about patients dying alone without the physical presence of either close family members or spiritual care providers. Only folks who are garbed in PPE with masks and face covering, and we would prefer it be otherwise. What can be done so as to enable patients who are dying to not die alone?
Well, my first thought is that it's very hard on a chaplain to be standing outside the door knowing that that person is dying alone because we cannot go in. And that is the reality of our situation as it currently stands. We can give to the nurse a prayer to say, we can equip that nurse as best we can with material to be able to help that nurse be the spiritual presence in that time. And that's what we are doing, and I would presume what we will continue to do. And obviously we'll be outside that room very prayerfully communicating, and then of course we will offer grief support via phone or in person if the family members are here. We have a fairly lenient, to this point, policy around end of life visitation, and so a person can have one or two, if they're COVID positive, one at a time, kind of with the person. So hopefully if there are family members, we actually will be able to have a family member with them at the time of their death. As we know, everything changes every day, so that may change, but that is our current stand. But the chaplain is outside the room.
And
Kathy,
I would,
what's happening at KU?
well, I would echo a lot of what Sally is saying, and we're finding ways to try to get the spiritual support to the patient in meaningful ways. With the chaplains having to be outside the room, there have been instances where a chaplain has said a prayer over, using technology that the nurse can take into the room. One of our chaplains described having the curtain pulled back. He was sitting at the nurse's station reading the prayers that were important for this family, that they could hear, they could physically see him, and then after the prayers were finished, they pulled the curtain so that the family could have their privacy, because we also have the ability to have some family members in. Of course, it's our hope that no one dies alone, ever. And so whoever it is able to be in the room, we want them to, again, be as best empowered to be able to provide that care. And then, of course, we're here to support that staff that may be the one that is in the room at that time. And it is a very poignant time to be with a family member outside a room, to be able to provide that support if we're fortunate enough in person during these, these times that are very different. So we're doing everything we can to provide that support and to be as present as possible.
Thank you so much to both of you, Kathy and Sally, for what you are doing in your hospital facilities, along with other colleagues who are doing the best that can be done under very, very difficult circumstances. On behalf of all of those patients and families who receive such care, I thank you.
Thank you.
Thank you.
I want to say that the views and perspectives we've heard today are those of Reverend Schwab and Reverend Riegelman, and don't necessarily reflect the positions of the Center for Practical Bioethics, although I did not hear anything today that I wouldn't say amen to. Thank you for joining us. Others who are going to be viewing this, thank you for joining us for this edition of COVID Ethics Update, which is a service of the Center for Practical Bioethics. If you have questions, ideas, comments, or suggestions for future editions, please email us at covid@practicalbioethics.org. That's covid@practicalbioethics.org. If you've not yet registered for the COVID Ethics Update, which happens most days, please go to our website where you can do that. That would be practicalbioethics.org. Thanks again for joining us. Be safe and stay well.